Saurabh, please continue.
Good morning, everyone. I thank AOS for the invite, and today I will be just talking about strabismus, the basics of strabismus, and the treatment options.
Please get closer to the mic.
So, what we will be discussing today will be how to make a diagnosis, how to plan a treatment, follow up, and learn and refine the surgeries. So, making a diagnosis, we should know what the exact history of the patient is, general inspection. We should be evaluating the motor functions. That is very important in any strabismus surgery, because if we don't evaluate the motor functions, we are not going to treat the patient at all. We should also know about the sensory functions, that is the vision and the refraction, and we should also along with do the ocular examination. So making a diagnosis is very simple. If the eye is in, it is esotropia. If the eye is out, it is exotropia. If it's up, it is hyper. If it is down, it is hypo. What is exotropia is basically when the eye is outwards. Then there are different types. If the near deviation, that is at 1 meter, is equal to that of distance, it is called basic exotropia. If the near is more than distance, it is called convergence insufficiency. If distance is more than near, it is called either true divergence or a stimulated divergence, depending upon if the distance deviation is more than near after a patch test, it is true divergence, and if it is near deviation which is more than the distance deviation, it is stimulated divergence. Esotropia can be congenital or it can be acquired. If it's seen with a history less than 6 months, it is congenital. More than 6 months, we put it into acquired category. Esotropias of congenital can be infantile, and it's one of the most common type of esotropias. Congenital esotropias, if there is also a limited abduction, then it can be Duane's or it can be sixth nerve palsy. Duane's, Dr. Miglani has already discussed. Esotropias can be acquired, and if there is a decrease in vision, it can be sensory esotropia. If there is high hypermetropia, it can be refractive. If there is high AC by A ratio, it is a convergence excess type of esotropia. So esotropia can come with limited abduction. So if the passive movement is full on forced duction, it can be acute sixth nerve palsy or a slip or a lost muscle. If the passive movement is limited, it can be an endocrine disorder or it can be a tight medial rectus. To proceed with the diagnosis, how to make a diagnosis, we do some baseline evaluations, especially with help of prisms or synaptophore. Synaptophore is obsolete, we normally use prisms now. We also measure the sensory functions. We identify the associated conditions along with the squint, and we also identify what factors are going to influence our results. So multiple factors can be there with just esotropia, exotropia. There can be inferior oblique overaction, or there might be some upward or downward movements in right and left, which can be called as X, Y, A, all different patterns. So everything has to be noted down, and we should always document our baseline photograph, because that is very important when the patient comes back to you and asks you, sir, farak hi nahi paya. So then that baseline photographs helps a lot, and also it builds up the confidence in the patient that you are going to do a very good surgery. So plan a treatment. Basic target is orthophoria or asymptomatic heterophoria, which is less than 5 prism diopters. Normal visual acuity, normal stereo acuity, normal retinal correspondence, and a stable sensory and motor functions. The treatment options, first is find out what the refractive error is and prescribe the refractive error. Most of the patients, they do turn to have a very good result because of the correction in the refractive errors. You can give some exercises or do occlusion therapy, but exercises, I have finally found out that doing exercises take a lot of your energy, and the end result is that we have to go for surgery. Surgery is, if you do a muscle weakening, it is called recession, and if you do a muscle strengthening, you do a resection. Resection, you cut the piece of muscle and just bring it forward. Recession, you just move the muscle from the original insertion a little backwards, and then you can do a muscle transposition depending upon the case. So which eye to be operated, how much to operate depends upon the doctor and the surgeon, and there are step guidelines which are there given in each and every test book, which we can go through, and according to that we can decide what surgery has to be done. Also we have to customize our surgery depending upon what we want the final result to be. You can undercorrect, you can overcorrect, you can do a muscle shifting, you can do a muscle transposition depending upon what you have initially. So surgical plan depends upon all these associated factors. I am not going to discuss them. Patient counseling is very important, because you are going to get some amount of diplopia which can be there for initially few days or it can last a little longer. So you have to tell the patient about the diplopia after surgery. And also about how to correct the vision if there is a vision is decreased. So amblyopia management also has to be discussed. Lot of patients ask that glasses bhi utar jayenge, so glasses will stay. That we have to tell the patient that glasses is going to stay. So finally we have to do many surgeries, find out what results we are getting. So we have to learn from our surgeries, learn from the published reports, and then refine on the next patient what you are going to operate. So decision making, I am going to just show some cases and discuss the treatments what we have given and see the results. This 23-year-old male, left eye vision is 2/60. The deviation was 35 base in, and which was equal for distance and near, and there was alternate fixation. Other things were all normal. So diagnosis was basic constant exotropia or divergent squint. The surgery was done in the left eye. The lateral rectus was recessed for 7 millimeters, medial rectus resection of 7 millimeters. We have to wait for 3 to 4 months to find out exactly what is the end result of the surgery, and if required we can do the other eye surgery. So target will be mild overcorrection to achieve the orthophoria with time. The case 2 is 21-year-old male, vision is 6/6 in both the eyes. Here the distance deviation is more than that of the near deviation, and on doing a patch test we found that the distance deviation was again more than that of near deviation. Other things were all normal. The diagnosis was true divergence excess exotropia, and the treatment was bilateral recession of 6 millimeters in both the eyes, and the target was to have a slight overcorrection or orthophoria after surgery. Case 3 is 1.5 years of male, present, started with squint at 9 months of age, vision was 6/12 on Cardiff. The deviation was 35 to 40 prisms base in, which was equal to that of distance, and there was inferior oblique overaction. Here we have to see very closely that there is any inferior oblique overaction or not, and that has to be addressed at the time of primary surgery. So diagnosis was basic exotropia with bilateral inferior oblique overaction, and the surgery was done was lateral rectus recession in both the eyes and inferior oblique recession in both the eyes, and the target was to have orthophoria. The conservative treatment in those cases will not help. Now in this type of cases where there is a refractive errors also, we have to start with the glasses and then we have to proceed with the surgical options. This 5-year-old male had onset less than 6 months of age. Less than 6 months means it's a congenital type. The distance was almost equal to near, and that was base out 45 prisms, and there was left inferior oblique overaction which was there in the right extreme gaze. So diagnosis was infantile exotropia, and the treatment done was in right eye, medial rectus recession of 5 millimeters and lateral rectus resection of 9 millimeters. The target was to have little bit of undercorrection, because with age the eye is going to, the face is going to grow, and I have seen that if we completely correct these patients, they are going to they have a tendency that they might go for exotropia with time, and also this child has mild hypermetropia, so undercorrection was targeted, and the rest of the correction probably with glasses would take care of the deviation. This case 5 of 7-year-old female, refractive error was plus 4.5 in right eye and plus 5.5 in left eye. The deviation was more for near and was more.
Dr. Saurabh, please wind up.
Yes, ma'am. So this patients need this was called refractive accommodative esotropia, and it was corrected with glasses completely. This case where there was a refractive error of 3.5 and there was a deviation of 50 prisms base out, which was more than that for distance. ACA by A ratio was calculated, which was very high. These were convergence excess type of esotropias. Glasses were given, still there was esotropia. These patients require surgery after some time. So the inferior oblique overaction, if it is only inferior oblique overaction, just inferior oblique recession was helpful in these patients to correct the deviation. This patient of third nerve palsy, because of trauma, needed a surgery which was lateral rectus recession with medial rectus recession and inferior oblique recession. Did very well after surgery. This is a special case very close to my heart. This was a heavy eye syndrome where there was a hypertrophy of 30 base up and 30 base out, and there was restricted elevation And when we were doing surgery, we found out that there was no superior rectus in the.
Saurabh, may I request you, please?
Yes, ma'am. This is last question. So what we did was identified that the superior rectus was missing. So the surgery was on table. We did a modified naps to this patient, and we got a very good result. There are so many others, but thank you all for the presentations. And I will end up with this particular case. This case very commonly comes to us, and this is not a squint. This is basically a pseudo-exotropia because of the telecanthes. Thank you, ma'am.
Thank you, Dr. Saurabh. That was a nice presentation.
Dr. Saurabh, I just want to ask you one question. So do you plan your surgery anything different for decompensated cases of accommodative esotropia from that of acquired esotropia? Is there any change in the surgical plan for both cases?
Decompensated esotropia means the patient is getting esotropia.
So patient who was well orthophoric with glasses and suddenly present with the esotropia and it persists.
Acute esotropia which persists with time.
Yes.
So initially we have to wait, give some.
But that is persisting.
Yeah, that is persisting. So similar to that of acquired esotropias.
They're similar to acquired.
No.